A wholehearted welcome to all of you to this second webinar of Impact, the Swiss Implementation Science Network. My name is Sabina de Geest. I'm the director of the Institute of Nursing Science at the University of Basel and also the chair of the Department of Public Health at that university. For those of you who joined the first time in this webinar, Impact was being founded about 2 years ago and has goals to showcase implementation science projects in health sciences conducted by Swiss health researchers and institutions. Also, we want to provide networking opportunities for implementation science researchers and other stakeholders, and providing training opportunities for implementation science. Leveraging funding options for implementation science in Switzerland is also our goal. For today's webinar, we have a program in which we will start with a short welcome introduction and the program, which we are doing now. And then we have a lecture and an interactive discussion from Dr. McKay and Dr. Naylor, which I will introduce in a minute. What I would like to ask you is to mute yourself during this lecture. And if you have questions, you can add the questions in the chat box. And there will be moments where we will select some of the questions to be discussed in a discussion round. At the end, there will be a conclusion and also an announcement of next event of the Swiss Implementation Science Network. We have 163 participants from 24 countries from 5 continents. So this is absolutely amazing and has really been the highest turnout ever. And I think it just indicates the relevance of the work that Dr. McKay and Dr. Naylor are doing. So Dr. McKay is a professor at the Faculty of Medicine at the University of British Columbia in Canada. And Dr. Naylor is a professor at the School of Exercise Health and Physical and Health Education at the University of Victoria, also in Canada. Dr. McKay's research program spans the life course from childhood to old age. She is best known for health promotion, implementation science, and knowledge exchange. She leads a multidisciplinary active aging research team at UBC. Her research evaluates the role of novel, scalable, health-promoting interventions on children's health and on older adult health, mobility, and social connectedness. She adopts an implementation science knowledge mobilization lens to evaluate factors that influence implementation, adaptation, and scale-up of effective health-promoting interventions as a means to improve health on a population level. Dr. Naylor research incorporates socio-ecological and setting-based approaches to children's physical activity, focusing on the environments where children live, learn, and play. She's also passionate about implementation and scale-up science. How do we facilitate the widespread use of effective strategies? Dr. Naylor was a key partner in the evaluation of the Action School, British Columbia, and other provincial scale-up evaluations as an appetite to play. I learned to know the work of Dr. McKay some years ago when I was studying implementation science. And it was her study that made for me the click to bring everything together in view of what implementation science, what kind of makes implementation science so special. And so I'm really happy that we now have both Dr. McKay and Dr. Naylor with us in order to inspire not only Switzerland, but in all these countries and all continents who are part. So I give you the floor.
Okay, there we go. Good morning, everyone. I'm going to just begin. Okay, you've set a difficult task for us, as we know that there's a lot of talent on the line right now. Many of you that have tuned in from around the world in different time zones, and thank you so much for that, are bringing to what we're going to do in the next 90 minutes a wealth of knowledge and experience. And we are going to be calling upon you to engage with us in our discussions throughout the morning. Thank you for the introduction, Sabina. Both PJ and I, many years ago now, gosh, I'm going to age myself right out of the starting blocks here, but it was in 2004 when I was working in the school-based system, and we saw that children in our Healthy Bone study were presenting with one, and in many cases, 3 cardiovascular risk factors at about the age of 10. And I thought that was terrible. I was incensed by that. And I went to our Ministry of Health, and we got together 3 different government ministries and said, it's time for us to quit talking about this, and it's time for us to do something about this. I had no knowledge of implementation science. It was not a term that was used then. Scale up was not really clearly defined. So really, I would say that my knowledge has evolved through practice over the years. There are many of you who have spent a lot more time in the theories and so on, but we have been living implementation and scale up science for about the last 15 years, and we're delighted to be able to share some of our stories with you. We will do our best to answer your questions, and we know that wherever we've made a reference to a theory or a model, we have the reference there, and you can go back and look at it. We're hoping the discussion today will focus on the things that only we can answer, the things that don't get written into our published papers and you can't find in the literature. So that's the kind of discussion we're hoping for today. So thank you for inviting me, and I'd like to introduce PJ, or have PJ introduce herself.
Thank you very much, Heather, and for everybody that's online. And I have been fortunate to be along the ride with Dr. McKay, Professor McKay, when we started out in the school-based initiative, which we're going to introduce today. And I would, I just like to say thank you for being here, and hopefully we have some lessons. And I am going to be facilitating today, and I'm delayed, so I'm probably going to turn off my camera because I'm working off a satellite that is, the internet connection is iffy. So you may be hearing my voice, but not seeing my face.
Okay, so okay for me to get started, PJ?
Oh, yeah, sorry, I apologize. I thought you were doing the land acknowledgement. Yeah.
It's coming up next.
Perfect.
Okay.
Okay, got you.
We are in a beautiful country, and we live and work in a beautiful province, and we'd like to say that we are very grateful to the Indigenous keepers of the traditional lands and unceded lands of the Squamish, Musqueam, and Tsleil-Waututh nations, where we have the privilege to live, work, and play. We are settlers on this land and acknowledge that our presence on this land with an awareness of our shared history with our Indigenous brothers and sisters. The agenda today, is here. We're going to start with a bit of a warm-up, an introduction that I will sort of get us all on the same page about some definitions that we're going to be using, and make sure that we're understanding them similarly, because we all know in implementation science, the same term can be defined in many different ways. And then we're going to work with you to tackle what we're calling some issues in scale-up science. So we've identified 3 of many issues that we would really like to hear your perspectives on. So we've been living these, we've been discussing these, we're bringing the evidence to bear on these, but we want to hear from you. And then we're going to present 2 different case studies where the rubber meets the road. So it's lovely to have theories and it's lovely to have frameworks, but when you try to take what's written in published papers and put it into practice, that's when the learning really begins. So we will share with you two different scale-up studies, one implemented over 11 years, Action Schools BC, and Choose to Move, and older adults that's been implemented now over 7 years. So, and that's the agenda. Take it away, PJ.
Thanks. So what we thought we'd really like to do is get to know people using a few quick polling questions so we understand who's in the room and what their role is. So the first polling question is going to come up right now. And if you take a minute to answer the question about identifying which group you most closely align with. Okay, we've almost got everybody. Good. Give you another 30 seconds. Great. Good. Has everybody had a chance to answer? We've got 7 people that haven't. We got about 87, 90%. Good. Great. Okay. It looks like we have quite a few academics and implementation science researchers and some health professionals or health practitioners and an implementation science practitioner. So we have a nice blend of research and practice on the line, which makes it really interesting. The second poll we're going to do is asking you about your experience in level of experience in implementation science. So we will, here it is here. Just choose the phrase that most closely describes you on this one. Whether you're an implementation science newbie or whether really experienced and doing a lot of work in that field.
Okay, PJ, I think we have everybody.
Great. So this is fantastic. We have a few newbies and about half of you know a little bit. So we have a nice blend across the levels with one expert. So it's looking like a nice blend of people. And I'm going to hand over to Heather to start us off with a few definitions.
I just need my screen back. There we go. Having some trouble here. Okay, and I know there's probably a lot of humility in the audience. I know some of you who are on the Zoom call and you have a lot of experience. So thank you again for joining in. Just to position us, we've heard a lot about a research to practice gap, where we have research evidence that may never get put into practice in different contexts, in the health promotion context or the health systems context. And you all know that the statistics that it takes approximately 17 years and 40% of studies are ever implemented in practice. But we do not want to live there today. I'm having trouble with advancing my slides, so I'm going to have to use this. this is where we want to spend our time today, because we are really interested in the second gap called the implementation to scale up gap. So once we have an intervention or an innovation that we know works, I think our responsibility as practitioners and researchers is to figure out how to get it to scale, so that it is not just conducted in a small trial. We publish it, our friends see it, our parents applaud our good work, but it never gets into practice. So it's affecting the health of more and more individuals. And this doesn't happen very often. So along the continuum from descriptive studies to scale-up studies in physical activity, these data are a little bit old now. This is Andrew Malat's work from University of City. He's a close colleague. And you can see that 65% of all physical activity studies that were published when he did this review were descriptive studies. And as we move from efficacy to effectiveness to scale-up trials, we see that very few of effective interventions in physical activity, and I would venture to say in all of health promotion, are ever scaled up. And I would venture to say that none are sustained. More recently, Samantha Gray, who's on the line, I saw your name come up, Samantha, so I might be throwing questions your way, so get ready. Samantha did a systematic review as a part of her doctoral dissertation, and she was looking at the older adult literature, and she was looking within that literature to see whether they referenced implementations or scale-up science at all, whether they cited indicators that they measured, whether they named a framework, and whether or not they were scaled up. And Samantha found that this is very recent now, this publication, only 4% of physical activity interventions or health promoting interventions for older adults were scaled up. So between 2011 and now, not much has changed. And this is good news and bad news. I mean, the good news is there's lots of work to be done. There's lots of studies that can be carried out by hopefully trainees that are at the webinar today. There's just a whole wealth of questions that can be answered. The bad news is that this is not happening, and it needs to be. Okay, a definition. The definition of scaling up that we're going to use comes from Simmons and Schiffman, and it's on the WHO ExpandNet website. The address is down there, and I know you can read this, but the idea for scaling up is in order to amplify the impact of any health innovation that we show in an efficacy trial so that it benefits more people, we have to put it into practice at larger and larger scale. And then you see at the end is on the lasting basis is that idea of institutionalization or sustainability, which is really the gold standard that all of us would like to achieve with our interventions eventually. So the first question I'm going to address is, where does scale up begin? And this seems like a pretty straightforward question, but along this continuum here, beginning with a pre-intervention or a pilot study or a feasibility trial or a formative evaluation, there's this really pretty little continuum that goes to an efficacy trial where we can control the situation and we can show that it works, and then we're going to scale up a little bit and go to an effectiveness trial and take a look at implementation strategies and see how they're affecting our implementation. And then over here, we begin to implement at larger and larger scale. As we go from these pre-intervention and efficacy trials where we have lots of control, we focus more on the impact of the evaluation at the person level, at the effect of the intervention on the participants in the intervention. As we move along and deliver at an increasing scale, we use more qualitative methods, and we can use hybrid methods. We can use, and this is published in Kiran's paper in hybrid effectiveness type 1, 2, and 3 models as we move from impact to hybrid type 1, which is using quantitative research approaches primarily, to hybrid type 3, where we're focused almost entirely on the process of implementation. What needs to be in place in this larger context of influence in order for us to effectively deliver an innovation. And as we move along this continuum on the bottom here, the scale and the reach of the intervention increases, and that's pretty straightforward. I also want to mention that this looks really pretty, but it's not. In real life, this is not pretty at all. Lots of studies go from a pilot study right to scale up if you're working with government partners that want to get this into play. Others go from an efficacy trial to scale up. Others don't do an efficacy or a pre-intervention trial. They will do an effectiveness trial. So this continuum happens in very many ways. So where does scale up begin? Does scale up begin after your feasibility trial as you move to efficacy? Does it begin after efficacy trial in 4 schools and now you're in 20 schools? Or is that scale up? Or does scale up only happen when I'm engaging all of the schools in a province or a country? Where does scale up begin? And we're going to have a discussion about that. But we contend the scale up is a process. Scaling up is part of the continuum. It is not an endpoint. You're never really scaled up. And our evaluation is this continual cycle of evaluation along the life course of any intervention that could go on for a very long time, hopefully. Okay, our next polling question, PJ. I can just take this one. So I would like to know, and I think here we go, you got it. So it's just that, and you answered this a little bit in the first question as well. I will never scale up an intervention. I would do it if I knew how, but it's a difficult and complicated process. I've done it. I'm really good at this. And what the heck are you guys talking about right now? What is scale up? Okay, I think we have just about everybody. Okay, can I end this poll? So, and I am with every single person who said I would scale up an intervention if I knew how, because that is exactly what that is exactly what we were thinking when we conducted a Delphi process to understand how we could do this more simply. I'll just wait for them to close the polls, or I'm just going to move it over off my screen. There we go. So what we tried to do, and this was really quite selfish, because when we got into the implementation science literature, it's really complicated literature. And it's confusing for folks. So what we wanted to do was we wanted to take scale up out of the too hard basket and really just give individuals a starting place to scale up an intervention and to better understand how to evaluate it. I'll just let you turn off the poll when we're done. And as I just said, when we first started this work, there were more than 63 frameworks that had been applied to help promoting interventions. And there were even more when you start to look at the health services literature. There's a whole array, and it's really tough to find your way through them. So what we did is we conducted a 5-round Delphi process, and Samantha's on the line here, and she was instrumental in helping us get this done with many other partners. And we talked to an international group of physical activity and nutrition implementation scientists with a self-declared 1 to 10, 11 to 20, or greater than 20 years experience as implementation scientists. This is just really weird what's going on here, but let me just persevere. Okay. And then what we wanted to do was, based on feedback from the participants in the Delphi process, we wanted to come up with a roadmap for those who are wanting to conduct scale up, want to scale up their studies and conduct an evaluation. And we landed on a roadmap of 3 frameworks that you should really know about and could use to apply, 5 outcomes, and 10 determinants that our participants thought were of the greatest value to them. And I'll just go through them briefly here, because if you're interested in them, you can look them up in the published paper that will be on our reading list. So the 3 implementation frameworks that surfaced were the framework for effective implementation, Dulac and Dupre's Consult with CFR, which many of you will know, and the dynamic sustainability framework from Chambers, David Chambers. What our participants knew a lot less about was scale up. So those who worked with government and had implemented interventions, physical activity and nutrition interventions within schools, for example, they were more interested in the scale up. And a lot of those who participated were more tuned to the implementation at small scale and of things. This is the Dulac and Dupre framework. And I just going to, again, not delve into the nuances of these frameworks. I just wanted to say that of the frameworks, they all comprise the same components. So in the center, this is Wandersman's interactive systems framework. There are systems that need to be in place to effectively deliver the innovation. But all of this is really embedded in a very dynamic, complex systems level environment of provider characteristics and community level factors like the social, political climate, policies that are supported, that all come into play to affect whether or not you're going to effectively implement an intervention and scale it up. And there's different ways this is presented, but these different components are very common among most frameworks. I'm not going to dwell here either, but the 5 outcomes that implementation scientists thought were of most value to them, there's hundreds, but thought that it was important for them to assess are listed here on the left, and implementation determinants are listed here on the right. So this is a starting place for those of you who want to conduct implementation of scale evaluations. What also surfaced from our Delphi process is that we're operating at a couple of levels. And I will be honest in saying it took me a long time to get this straight in my head. So looking at the determinant acceptability, for example. So if I'm looking at the acceptability of the acceptability of the intervention, say to a teacher who's delivering a health promoting intervention within schools, that's delivery of the intervention. Teachers are at the front face of delivering the intervention, and is it acceptable to them or any member of the delivery team? Delivery of implementation strategies happens in those outer circles. So is the organization across levels that you want to evaluate, are the implementation strategies acceptable to them? Is the school on board to deliver the intervention? Is the school board on board? School trustees? Is the Ministry of Health on board? So the implementation strategies really pertain to those outer levels of influence. And then you can, when you're doing the evaluation, you could conceivably evaluate at many different levels. So what did we learn? Well, we learned that it is a bit of a mess out there, and some terms were defined differently depending on sectors. Implementation science is very sector driven. There's not always a lot of communication across sectors. If you're in the health services sector, you call these terms something differently than if you're in the health promotion or mental health or child welfare sectors. There's often a mismatch between the frameworks and evaluation indicators. So if I'm using the Dulac and Dupre framework, and I've got all of these factors, then I should have indicators that allow me to assess these factors. And then I should, at the bottom here, I should also have measures that allow me to do so. And we learned early on in the Delphi process that there's not a lot of validated measures and tools that are ready to use. And we used a lot of qualitative methods, so a lot of work to be done in establishing valid measures within implementation science. So we are going to pause here. You've heard enough from me, just a little taste of and beginning to get us into our first discussion. So I'm going to throw this back over to you, PJ, and I am going to quit sharing my screen for the next 10 minutes for this discussion. This is really, really difficult here. I can't bring this up. Sorry, guys, I'm having a bit of trouble here. Can
maybe AVL can support and quit the share screen.
Thank you. I can't, my share, oh, here, I got it. There you go. It came up. Okay, PJ.
I've been chatting away, I apologize. What we're looking to do is use the chat box to have a little bit of a discussion about where on the scale up continuum you are working. Are you working closer to efficacy and effectiveness and monitoring implementation there? Or are you up looking at implementation after scale? And then also what level you're measuring at. Are you measuring at the level of the delivery agent, the teacher, the clinician that's delivering the intervention to older adults or children, or are you looking at implementation strategies? So you may be working with the support system and their satisfaction and how things are working in terms of feasibility. So if you want to enter into the chat where you're at, this lets us all see where everybody's working right now. I entered something in there just to give you an idea of what we're looking for. Okay, somebody's at the feasibility.
I think, PJ, you can also accept questions if someone wants to come on video and ask their question live.
Yes. Yeah, thanks. And I trust Juliana will give me the heads up because I've only got about 16 people visually. Oh, I saw a hand. Jenny Oxier?
Yeah. Hello.
Can we unmute Jenny?
Sure. My question is, or maybe comment about where I'm at with the phases of scaling up is, I'm really looking at client level perspectives on the use of a digital health service in perinatal care. And what's interesting for me is that I feel like I'm a small piece of the beginning because I'm not checking on organizational acceptability or a little bit from also the nurse's perspective, but we're really focused right now on the clients, the users, the consumers. And so that's where we're at, and maybe others have something to bounce off of that comment. But I hope after my PhD that I can move into investigating these questions of acceptability in a broader context. But of course, I want to focus first with the consumers and the client level.
Thanks. Yeah, that's the stage you can't get through, but some of the things you find out, even in the feasibility phase, do lead to your ability to scale up. The more appropriate the intervention, the more flexible, the more adaptable. Some of Roger's diffusion of innovations issues from the patient engagement perspective are critically important, because you'll see in the models that Heather and I do in our case that the innovation itself has to be highly acceptable at multiple levels. I see Elena Peruzzi says, we have some prototype implementation strategies, how to spread at the national level. Elena, I would like to ask, what are your prototype implementation strategies that you've developed? Can I see her here?
You need to unmute, Elena. Could you unmute, please? Thank you. on the bottom left-hand corner.
Okay,
Oh,
I did. Sorry.
you can't. Or,
Sorry.
okay,
We
you got
did
it.
some experiments to change clinical practice just in a little space. I am from Italy, in a little space that is quite particular. So this means that could be spread at national level. My real problem is how to pass from the research to real implementation in the country, how to change the mindset, how to spread the results. Thank you.
PJ, can I take this one?
Yes, I was going to say Heather's going to take this one.
You know what? First of all, congratulations, Elena. I mean, that's a really lofty and important goal. As you scale up at greater and greater levels, then you have many more stakeholders who are invested and will want to have a say about what you're doing and how you're doing it. And you will see in our presentations that are to follow that partnerships are key. So the first thing that I suggest you do is, who is it that needs to be on the table that you need to commit to what you're doing before you even begin the process of scale up? So this is the whole idea of authentic partnerships. Who are the partners that you're going to need to support you in the beginning to adapt and adapt and establish a best fit for your intervention, but also they become your dissemination partners later on. So to me, that's the biggest thing. Just do a mental checklist. Okay, if I'm trying to do this in the health systems sector, I'm going to begin in hospitals in my region. Who are the key players in those hospitals? Who's making the decisions? And so I think that's the first step. And then you can evaluate based on those indicators and outcomes that we've already told you. Is your intervention acceptable to them? Is it going to be a priority within their organization? Right, and that's really the first is how are they accepting, understanding your innovation, and then only then will you start to figure out how to put it into practice. PJ, do you want to add to that?
No, it's exactly what I was going to say. Is one of the things that we'll talk about in our cases is the fact we even went out the door at feasibility with policy, research, practitioners all together as we design. So those partnerships become critical. It's not, you can bring them in at any point. Really important to get in front of decision makers at whatever stage you are and bring people into the fold. Looks like there's a couple of other people online that are actually looking at implementation factors and strategies. So very different levels of implementation. So I think we'll move on now. I don't see any other questions, but if you have questions, keep putting them in and we'll deal with them at the next break. That was really nice of you guys to participate. So we'll move on to our next case, and Heather's going to share her screen for me. I'm going to try put my video on, and if I lose voice, I will turn it off, but Heather's going to change the slides. So here we go. We're going to, as we said, we're going to present 2 case studies, Action Schools BC and Choose to Move. I'm going to deal with Action Schools BC. And what's really interesting is both of these cases are under Dr. McKay's leadership, and a group of researcher, policymakers, and practitioners we actually spent 14 years from development through to scale up and 11 years in scale up. So I'm going to do a little bit about introducing the intervention to you. There's quite a bit in literature about this, and then just talk quickly about scale up. So at the school level, our innovation or intervention was called Action Schools BC. It was a flexible, choice-based whole of school model based on comprehensive school health framework. In Europe, you would call that the health promoting schools framework. Each school could customize an intervention across 6 zones with the purpose of integrating physical activity into the fabric of elementary schools and maintaining them through partnerships with family and community. So you see here at the school level, schools had choice and they looked at what they needed and tried to increase. One key area where we did prescribe was in classroom action. We asked schools to add 15 additional minutes of physical activity in addition to their normal physical education. And then the next slide shows what happens at what we did at, and it is this partnership piece that Heather was talking about. At the broader level, maybe I can, oh good. At the broader level, it was informed by socio-ecological theory and this was supported through all phases. But you see here, we had horizontal partnerships across sectors, the different education, health, government sector to the not-for-profit sector with parks and recreation and sport and regional health authorities. And then we also had vertical partnerships with the education, right from teachers to superintendents and the school district representatives. So that's horizontal. And then within there, we have our vertical partnership. And in addition, our program delivery team also had a technical advisory committee of about 50 very experienced teachers and administrators to help with co-design of resources and training. And you can read our manuscripts, but in the efficacy trial, we saw a significant difference in physical activity delivered by the teachers. And at the student level, we saw a significant difference in physical activity measured by pedometer, large effect in cardiovascular fitness and bone strength. And despite taking time away from academic lessons, we didn't see a difference in academic achievement. It was the same as in usual practice. 90% of teachers were satisfied, 70% were satisfied with their workshop resources and support, and 70% were really confident in their ability to deliver more physical activity. So we had the evidence we needed for the government, who took that evidence and decided to scale up. Thanks, Heather. In the next slide. And this was really important in scale up. Now, Heather talked about the different frameworks, and she's going to introduce one framework by Yami, scale up framework. And I'm going to talk about our case in terms of Simmons and Schiffman's scaling up. And these are some of the elements they bring up. And one of the outside rings you see here, the purple, one of the key factors in that environment is having evidence to work from. Second one was is some of the characteristics of that are having partnerships in place and having a scale up strategy, et cetera. So that's in the environment. I talked to you about the innovation, some characteristics Simmons and Schiffman would say relate to Rogers diffusion innovation. Is it flexible? Is it adaptable? Is it compatible with the setting? And this is going to become really important as we talk about the resource team. And then I'm going to just dig at the bones a little bit more of the resource team. The scale up strategy are things like communication and marketing, having a technical support unit, having the partnerships in place, and some feedback mechanisms. So the next slide will show you more in depth what the importance of our resource team was. We worked with a team of physical activity experts who had 20 years of experience in the schools. And here's where Action Schools sometimes often departs from other research-based models, in that when we went out the door, we actually created the intervention with the resource team in partnership with us as researchers. So some of the elements that are there that Simmons and Schiffman say are important to the resource team were there because of our resource team had a deep appreciation of the user's organization capacity and limitations. So here you see some of the factors really that this resource team had a high credibility with the user organization. They had already been rolling out physical activity strategies, and a deep appreciation of the user organization's capacity and limitations. And they were also partnered with other stakeholders like education, health, sport and recreation. So what happens there is they have an understanding of the political, social, and cultural environment and what's needed. So these are some of the factors Simmons and Schiffman come up with related to each of the key elements. If you're interested in the other factors to address in your practical scale-up strategies, I suggest going to their chapter in that WHO sponsored text. Next slide. I think there's going to be a little transition there. Thanks. So one of the things in the scale-up strategy that Simmons and Schiffman recognize or highlight is the need to have a phased approach. And we did have a phased scale-up of Action Schools BC. We moved from development way back in 2002, 2003 with our policy practice research partnership into our efficacy trial and then the effectiveness. And then you see we phased in the healthy eating pilot, and then we conducted a couple of scale-up studies, and you see implementation at scale started right after the efficacy. I'm going to be introducing you to some data from Lindsay Nettlefold's PhD, where we are able to look at our efficacy effectiveness trial data to understand what happened in terms of delivery and outcomes in scale-up. So this is Lindsay Nettlefold. She may be online, I didn't see. And of course, Heather and our other colleague, Heather McDonald. And we looked at how does voltage drop at scale affect student level outcomes using the cluster randomized control trial during the effectiveness phase. So what did we do here? The paper itself, if you want to read it, addresses 3 objectives. But today I'm just going to talk about describing strategies that supported implementation and scale up. And secondly, we'll look at evaluating implementation and its impact within a 2-year cluster RCT. And the reason we're going to present this is because it really brings to the surface those issues around scale up that we want to have a discussion about. So what we did methodologically is we looked retrospectively at all of the Action Schools BC statistical reports and annual reports for over 10 years. And we looked at the implementation strategies, categorizing them, aligning them with taxonomies that you can find in the literature with Lehman, Powell, and Proctor. And then we also looked at reach of both the implementation strategies and the intervention. And what did we find?
Sorry, I'm in trouble with
Next
my
slide.
mouse.
We found, no worries. Things are always. So we found 13 different implementation process strategies that we used. You can read them here, but we did talk about our resource team, which Simmons and Schiffman says, we call that technical support or technical assistance. You see them on the left. We found 7 capacity building strategies. One of the primary strategies was ongoing training and making the training very dynamic and obtaining and using feedback. They all completed planning tools to identify where they are strong. We fed their reports back to them. And then 5 different scale-up strategies where the resource team worked with weaving the network together, and they trained in post-secondary educational institutions, distributed materials, and used marketing communication to increase demand. So quite a few different implementation strategies were used across that. And the next slide is about reach. And when we describe reach, by the end of year 2 of the scale up 2 and 3, that there had been presentations to all of the school districts. There are 60 school districts in British Columbia. By the end of 11 years, there are greater than 500,000 workshops. What this boils down to is approximately 500 workshops a year. Our resource team was incredible at getting out. There were over 220 Action Schools BC trainers. We had a regional network of people that conducted the workshops and went to trainings every year, but about 75 were deeply active in training at any one time. And then when we looked at the reach of the intervention, we reached over 90% of the schools were registered and some training had occurred. And this reached about 87,000 teachers and administrators and approximately 500,000 students. So our reach was quite substantive in the province. So what does this mean at the outcome level? When we are looking at, we talked about the efficacy level. So when we looked at the physical activity delivered by teachers, we start to look at something called voltage drop. And this is, you see here that we got a significant difference in physical activity delivered by teachers that were trained during the effectiveness trial in year 1 compared to the usual practice. And they provided approximately a mean average of 34 additional minutes. This started to drop off in year 2. We saw a little voltage drop over time.
Sorry.
And what's interesting about that, I want to highlight for you, sorry, don't worry, during the efficacy trial, they delivered about approximately between 45 and 55 minutes, depending what arm, but approximately 50 additional minutes during the week. So you see a voltage drop from efficacy to effectiveness and over time during the effectiveness trial. What impact did this have on the student outcomes? We see here we got the same size of effect for fitness in year 1, greater for the girls and the boys. And when we looked at our univariate analysis before controlling for cluster, we saw a significant effect in year 1. But when we controlled for cluster, there were a few numeric issues because of some scale-up issues, which we'll discuss online in a second. But so we saw the similar effect size and lost significance when controlling for cluster. But and this may be because over time we had some issues and the voltage started to decrease in year 2 again. So, so we wanted to look at, many of you may have read David Chambers' paper reviewing interventions, health promotion interventions, and the voltage drop. And the median voltage drop they found was about 59%. And we compared our voltage drop between efficacy and scale up, we had about 64%. So our findings are fairly in line with the literature to date over the type of voltage drop that's there. Now, we wanted to take a little break now and again, open up the chat to ask the question, is voltage drop inevitable at scale up? And what do you think are the potential reasons for voltage drop? So we're going to open up the chat, and if you can enter that in, and then if we close our screen and let, then if you want to raise your hand, we will take a look. Now I got to get through. I'll give you one of our reasons is we had job action, a school teacher strike after just in year 1, and we lost a lot of numbers in our baseline. So one of the reasons we may have had voltage drop is just our power. We were powered for the cluster, and we lost some data. So that's one reason at the research end for our voltage drop. So how about you? While you're typing in, a second reason is that what happened in the school system is teachers changed classes and classes changed teacher from year 1 to 2. And after the job action, we got some new teachers. And when we did, we only provided a refresh, and we found about a 25% difference between the teachers that had prolonged engagement over the 2 years and the newer teachers that came on after the job action. So these are 2 real world examples of how you end up with voltage drop despite trying not to. Heather, do you want to pipe in with?
Well, you know what? I think Heather McDonald, who is a co-author on the paper, is joining the webinar. And Heather, I wonder if you would begin the discussion about what you think, whether or not voltage drop is inevitable and maybe what the reasons are for voltage drop. I reread the Chambers paper this morning, actually, and he strongly suggests that it is absolutely not essential, and that adaptation over time should in some cases improve the effectiveness or the impact of interventions because the context is shifting. It's this dynamic sustainability framework. You've got this dynamic context within which you're implementing an intervention. So maybe it's not inevitable. But I'd love to hear from Heather McDonald, if you don't mind unmuting, Heather, and telling us what you thought as you were so closely engaged in this intervention. I see now that she's not on PJ, so we can take other questions.
That's great. And I see Elaine has added, she's struggling to understand why the iPhone or some of the apps and applications we use don't decrease voltage. And that's a great point, Elena, in that, as Heather pointed out, that Chambers says that a voltage drop is not perhaps always the case. And you're quite rightly pointing out there are some things that are so tempting and moving all the time to adjust to needs that they don't lose voltage or application. Great point. I would like to point out in Action Schools, our resource leaders knew this. And so what's happening as our research team is sort of fixing in place these trials that you saw, the resource team was continually surveying the teachers and administrators and finding their new need. So for instance, student leadership and mental health and anti-bullying became an issue. So we ended up with a huge student leadership training, and self-regulation became an issue. So they positioned physical activity training in terms of self-regulation and allowed choice for teachers to select different workshops. So those are some of the strategies we used to keep physical activity on the agenda. It's a bit harder on researchers, however, as the practitioners are adapting. And Heather's example of Choose to Move is going to be fantastic because their research team continuously adapted. Okay, not easy in the health field. A refresher and an update can be a factor. Yes, Suzanne. The refreshers and continual contact are necessary. Go ahead, Heather.
So PJ, I was unable to call on Heather because she was on earlier, but I know that Samantha is on. So Samantha is the key, is a doctoral student working with me who's really been instrumental in the success of Choose to Move. Can you talk a little bit about voltage drop, Samantha, scale up proceeded? I think they're pretending not to be online. Right, Samantha? Are you there? I can see your name. Okay, we'll leave her. There might be some technical problems. I think we can probably move on, but I love the notion of voltage drop because I do believe that the understanding, so we've got two schools of thought, and the one is from researchers where we want to, as much as possible, hang on to the fidelity of our intervention. We want to implement the intervention as planned, and we might have time to discuss that at the end, but I don't think so. So we want to hang on to the intervention we designed. But in order for it to be compatible and probably palatable to our delivery partners, they have to adapt it based on their capacity, based on the capacity to deliver, based on their priorities, based on their needs, and so on. So I love Chambers' notion that adaptation is a really, and voltage drop is not inevitable, because if you keep changing the intervention to the wider context. So if I begin in downtown Vancouver, and then in a year's time, I'm in the northern part of British Columbia where it's snowy most of the time, or I'm in the city core where it's very low socioeconomic groups, I need to adapt to those different recipients and for the delivery partners. So I like the notion that voltage drop is not necessarily inevitable. Okay. Do you want to, should we move on, PJ?
Sorry, yes, thanks, Heather.
Okay. Okay, so I am on here, and I apologize for not muting my microphone during PJ's presentation. I was hidden by my share slides. I couldn't get to it. So I'm going to take us to the other end of the life spectrum and introduce you to Choose to Move. And this is a health promoting intervention for older adults that we've delivered at increasing levels of scale across 7 years. And I don't know how many of you work in the older adults field, but you probably know that among residents of most countries around the world, older adults are among potentially the least active. And this is despite all the benefits we know that can be gained from physical activity. In fact, 90% of older adults are sedentary for about 8 hours each day. So this is a population that we absolutely thought needed our support and attention. And of course, these statistics have only become more dire as COVID-19 changed all of our lives forever, and this has quite devastating consequences in Canada and elsewhere, especially on older adults. So with a host of community partners and with our Ministry of Health, we co-created a program called Choose to Move. And it's a choice-based physical activity, health promoting physical activity intervention designed for older adults. And it's not a prescriptive program. We call it a wraparound program where older adults get together and decide on the activity that they're going to engage in, what they're capable of engaging in. And then the job of the Choose to Move program is to keep them honest, keep them engaged in the activity. And Choose to Move has 3 components listed here. A one-on-one consultation where the activity coach here on your left engages the older adults in activities that they love and think that they're able to do and stick to over the course of time. The motivational group meetings, there were 4 of them. I'm looking now at phases 1 and 2 of Choose to Move. And in these motivational group meetings, the activity coach used to engage the older adults with him or her, but also among themselves. And this was the vehicle for promoting social connectedness among participants. And then there were telephone check-ins where the activity coach called on occasion to see how everybody was doing. You can see at the bottom here that there were 2 phases of Choose to Move, a 3-month active phase where the activity coach was in touch with the older adults way more often than the last 3 months, the maintenance phase where the activity coach was connecting with older adults less often. So I have the implementation structure here, and those in implementation science will be interested, and others of you can take a little nap here. But we actually implemented and evaluated Choose to Move across these different levels. So beginning at the top, our prevention delivery system was comprised of these groups. So community organizations, so they were organizations that had the reach across the province of British Columbia to older adults. And these we were working at the level of CEOs of those organizations. Provincial coordinators were those within the province who were engaging Choose to Move in different ways. Recreation managers and coordinators were in the rec centers where many of the activity coaches were working, and they were involved in hiring the activity coaches. And the activity coaches themselves, who are the front-facing part of the Choose to Move model, and they were the ones in direct contact with the older adults. The prevention support system was a subset of our active aging research team, and we provided all of those elements that are crucial to implementation success, like training, technical support, ongoing contact. We had some focus groups and interviews to better understand what was working, what was not, and then adapting on this IKT model in real time so that the older adults could stay engaged and the activity coaches had what they needed to deliver. And then the active aging research team also conducted all of the evaluations, the implementation evaluation and the impact evaluation of Choose to Move that I'll present to you right now. So as per Yami's model, phased and integrate, a phased scale up is most effective. And I'll talk to you about Yami in a second. So we did the same as per Action Schools BC. In fact, many of the lessons I learned in my years with Action Schools BC and in working with PJ, I just stole them all and I applied it in the community setting to Choose to Move. So we began with a transformative evaluation, and you can see the phases that we went to with Choose to Move. where I'm focusing now on phases 1 and 2. After phases 1 and 2, we worked with our community partners across all levels that I just showed you on the previous slide to understand how we could better adapt both the intervention and our implementation strategies for best fit of the intervention. We adapted, we're now in the process between phases 3 and 4 of optimizing Choose to Move. So what does that mean? As a part of our intervention, we're also conducting a health economics evaluation. We're looking at the return on investment for our government partners. And what they want to see is they want to see us retain the benefit of Choose to Move while reducing the cost. So we conducted an adaptation to understand what were the core functions within Choose to Move that needed to remain, and those that could be moved or changed in order to reduce costs. So we're in the process of doing that now. And Samantha's work was really in adapting Choose to Move when COVID struck 18 months ago in March of last year, so that we could deliver Choose to Move in the home environment. And my team are superheroes in my mind and in my heart, because they very rapidly, within a month, we had adapted Choose to Move for a virtual environment, and we're engaging any older adult that had ever been involved in Choose to Move previously and trying to re-engage them so that we could keep them connected during the pandemic. And this is Samantha's work and a part of her thesis that she will defend next year. And so what did we hear from our delivery partners across those levels? Well, we plugged this into Yame's model, and Yame's model, it speaks to, well, so Yame is a global health scientist, and his scale of work was really done in insect netting in East Africa, global scaling up use of these nets. So he has nothing to do with health promotion, but I love the simplicity of his framework. And he speaks to attributes of the model, the implementers, the delivery strategy, attributes of the organization, the social political context, and the research context. And many of these attributes that he names as essential surfaced as being in place and important to those we were asking to deliver Choose to Move. I'm only going to focus on a couple. And here I am harping again on committed partners. We know the scale up is difficult. It's almost impossible without resources to do that. We were very fortunate across 7 years to have committed government partners. So let's look at some results here, the implementation evaluation first. So Choose to Move began in 8 communities, and currently we've been in 87, probably more communities now. We delivered 8 programs, currently 318 programs. We began with 67 participants. We've now engaged over 3,000 participants in our evaluations, and more than 6,000 older adults across British Columbia have been exposed to parts of the Choose to Move program and engaged in some way, whether or not they were evaluated. And you can see here a map of British Columbia, and we are all over British Columbia. And you also need to know that as you move from the major city here, down here's Vancouver, and out to the northern parts of BC, adaptation comes into play. They have less capacity. It is much more difficult for them to do these kinds of things. So we work more closely with those communities to give them the tools, the training, and the skills they need to deliver Choose to Move. And those are lasting skills that they use for some of their other programs. So looking at dose received as one implementation indicator, 82% of older adults attended 75% of the group meetings, and 95% completed 70% of the check-ins, and that's really good. So they were showing up to the group meetings, and they were showing up for the telephone calls, although the activity coaches found the telephone calls tricky because they usually had to call more than once in order to get the older adults on the phone. And I apologize for the busyness of this slide, but what I'm trying to do here is show you across at the top here, the levels of our delivery partners that I've already introduced to you, what they said were important factors for them that were provided within the Choose to Move implementation model that helped them to successfully implement. And you can see that some of these factors cross two levels. Financial resources were important to organizational leads and recreation managers. Social support was especially important to activity coach and participants. And I want to just focus on two of these. Again, political support was really important to our organizational leads and to us because the government was funding us. So our job was to keep them engaged and informed throughout the life cycle of Choose to Move and, in fact, Action Schools BC. The activity coaches were the heart of Choose to Move. The participants became very attached to them, and they worked really well in engaging participants with each other. The research coordinators were the ones who spoke most clearly about the important role that activity coaches played in Choose to Move. And you can read this. Joni Sims-Gold is really key. She's here in spirit, but absent in presence. She and I are the ones who have worked together over the last more than a decade in developing and implementing Choose to Move. And her paper that talks more about this is down here. So some of the lessons learned from Choose to Move are here. So I'll give you a minute to look at these, and you're going to say, oh, this is starting to look familiar. So a lot of these key elements surfaced in Action Schools BC. Many of these key elements surface in these frameworks that support implementation and scale up. But let me focus on a couple here. Authentic partnerships are key. Here I go again. I cannot say enough. Those that you engage at the beginning become your adaptation and dissemination partners in the future. They are key. Adaptation is inevitable. It is not your enemy. In fact, if we're all doing our jobs and scale up, we're listening very closely and we're using evaluation tools and techniques to get information back as to what's needed to adapt the innovation and our strategies going forward for different populations and for different settings. Evidence matters. Government hates to pay for the research part of these interventions. We actually applied for and were successful in bringing in external funds, but they love to hear the results of the interventions. And of course, we want to share what we learn with academic colleagues. So this research as a part of the IKT model is really, really important. So the impact of Choose to Move in phases 1 and 2, and again, you can look at this publication, is that we saw a significant increase in older adults' physical activity and mobility, their social connectedness increase, and their loneliness decrease. We have not yet published our phase 3 results. We've just been looking at them now. This is Heather McDonald's work, and we see the same kinds of trends occurring. We saw a significant increase in physical activity and mobility, social connectedness, and a decrease in loneliness at larger and larger scale. However, we're also seeing a voltage drop. So again, not inevitable, but here you go. So what did we change between phases 1 and 2 and phase 3? We're looking right here where we adapted to enhance best fit between phases 1 and 2 and 3. And what did that mean? In phases, so really it means we added group meetings and we decreased the phone calls. So we listened to the older adults. They wanted to get together more. They wanted more opportunities to interact. That's how the innovation itself was changed based on feedback. And here's what we saw in terms of voltage drop. Let me get our faces out of the way here as we went to larger scale. So this is the percent of the phases 1 and 2 effect that we saw that were maintained in phase 3. And we looked at this in 2 age groups, the younger group from 60 to 74 and the older group who are greater than 75 years. And we saw 53% of the effect of physical activity maintained in the younger group and almost 100% of the effect retained, in the older group. Mobility, 53% in the younger, 15% in the older group. So we're seeing that drop in mobility as we went to larger scale. Got the most finicky little thing here. In loneliness, we saw 74% of the benefit maintained in the younger group and only 35% in the older group. But if you think back now to how the intervention was changed and that we added more group sessions, we were not surprised by the fact that we saw a voltage surge, if you will, in the benefits of Choose to Move for decreasing social isolation, 122% increase in the benefits of Choose to Move for social isolation in the younger group, and a threefold improvement in terms of decreasing social isolation in the older group. So voltage drop is not necessarily inevitable. So that is our last slide, and we're going to take a minute to engage you now in a discussion of fidelity versus adaptation. I would love to hear from you. We've got 10 minutes left, so I would love to hear from you about what adaptations you've made to your interventions and to your implementation strategies, if you choose, and then how you would have balanced fidelity to the intervention while being really aware of and adapting to the needs of your implementers and your other stakeholder groups. Or in the last 10 minutes, you can join us in the chat and just ask any general questions about anything you've heard today. And I'm going to send this back. I'm going to quit sharing my screen, and I'm going to send this back to PJ to tackle some of these questions with you. Thank you very much, everyone.
Great. Well, we have about 10 minutes before close. So before Sabina does some closing remarks. So if you have anything to say about your adaptations or general. Or if you want to raise your hand, then we can make sure we
PJ, maybe you can share Suzanne's question.
Thank you. Thank you
okay. Yeah.
for the presentation. Well, the presentation made me think, and probably some members of our team, about this issue of sustainability. So you do your feasibility, you want to make adaptation because you want to have this uptake of the intervention, and then you do your assessment. Basically, during your assessment, you are not manipulating the environment, you are just collecting data to see over a year how fidelity is moving and how the team is acting with this, interacting with the intervention, and so on. So the question is, what do? You just do your assessment and leave? Would you provide another refresher after 6 months? So yeah, it's a question.
PJ, do you want to address it from the action skills perspective?
Yes. I think there's a couple of things there, mostly from the literature I'd be answering, in that most of our capacity building initiatives, feeding back assessment results is audit and monitoring is really important part of the implementation strategies. So I would suggest that is critical. The second thing is we continually refreshed. The interesting thing for researchers, though, is that the needs in the school system changed because something would become more important. Like I said, self-regulation became the issue. And then how do you keep physical activity on the agenda when the teacher is now thinking, what do I do for self-regulation? And so our team actually adapted the physical activity workshop to meet the needs of self-regulation. So there were modifications. But I will pass it over to Heather to talk about Choose to Move in that regard.
Yeah, so thanks, Suzanne, for that question. I mean, you really hit the nail on the head. I mean, it has to be refreshed in terms of making sure that with adaptations, that training keeps pace with whatever's being adapted. So as you're adapting the intervention, you're often also adapting the training modules. And we created a communities of practice, if I'm understanding your questions, for activity coaches, so that they could come together and continually have a discussion about how they were adapting delivery and how their strategies needed to change as a result of that. PJ wrote into the chat about the importance of policies and so on, but there's also this outer context where there's a school system that for Action Schools BC, there's a school system that you're bringing into the conversation, and they don't adapt that. They don't necessarily want to change what they're doing at all levels, despite what's happening at the front-facing sort of delivery levels, which sort of speaks to the importance of engaging them and asking them whether there's a need for a refresher, asking them if their training still meets the needs of their ability to deliver and so on. So that's that constant conversation that goes on, and you can be driven by what you hear across levels of implementation and evaluation. If I'm understanding your question, Suzanne.
Thank you so much.
Jenny has a question, PJ.
Jenny, do you have your hand up? Yep. Sorry.
Yeah.
Yes, Jenny.
Thank you for the great presentation. I have a quick first question and maybe a bit longer second. Do you have any resources around a choice-based program approach? Are there any others who have used this approach that you could guide me towards direction, learning more about it, how to design something? It sounds pretty intuitive that we want to run programs like this, but is there anything that you can?
We stole shamelessly from the CHAMPS model, and I can actually, I don't know if someone can pull that up. So this is work out of Stanford, Abby King's work. So they actually were the one well-known physical activity intervention for older adults that scaled up and was sustained over time. So, and they go through and they actually do a really nice job of describing their choice-based model. I don't know where else they exist actually, Jenny, but I think if you take a look at Abby King's work, you'll be in a pretty good spot.
Okay.
PJ, do you have others?
Yeah, Jenny, are you thinking clinical care choice-based models? Or are you thinking there's quite a few in public health? A lot of the school-based researchers have adopted more comprehensive school health informed, and one of the factors in health promoting schools is school level choice. In Australia, there's a couple of researchers, Dave Lubins and Chris Lonsdale, who are doing more of an online virtual choice-based model. And there's also a couple of other initiatives there under Joe Salmon's group. And in Europe, you would probably look, give me a second. I'm having a 60-year-old moment, and I will type in another research group's name in a second as it comes back to me. But those are more public health orientated, which is a very complex environment. Are you looking for clinical?
Yeah, I work in health promotion for perinatal care. I also have my foot in some clinical work with perinatal care, but when it comes to choice-based, my idea would be around pregnant women or postpartum women having a choice to make certain lifestyle behavior changes that will suit them, and we can use digital health to support those decisions and goals.
And one way we dealt with that, sorry.
No, it's okay.
One way we did deal with that in Action Schools, and Heather will talk about this, is we did within the choice-based model fix some level of dose and put that in the mind. And we're just interviewing early years practitioners, and they're saying the same thing. They want some practical advice, like put in something twice a week, or so there is some flexibility. But also, if you have a certain level of dose to achieve your outcome, how do you do some level of constraint to your choice-based model to ensure you get some outcome? So they can choose how they get to their physical activity outcome. The goal is there. And so that's one thing that Heather and our group made sure of in Action Schools BC. We still see the voltage drop, but there was always a guideline around how much and how they got there was there were.
And I know we're out of time and we're going to pass it back to you, Sabina, but just to say that this is really key in implementation science and deciding what your core functions are, what cannot be changed. So you would keep those core functions regardless. You could probably adapt the implementation strategies if they're not driving outcomes, but those core functions you want to try to be true to and provide the training and skills for your delivery system to deliver. Thanks very much, everybody. Back to you, Sabina.
So first of all, thank you wholeheartedly for this presentation that really provided us with this next phase of scaling up, which until now was not really the focus of our webinar series, nor the other type of presentations that have been given. And it really shows how true impact can be achieved, but also the complexities of it. And I would like to say that what I keep from your lecture is many things, but what stands out is this, what you call the scale up gap. I think we also have to mention that it's not only the implementation gap, but also the scale up gap. And then that there is not only voltage drop, but there can also be voltage surge. That I liked. I think this was quite impressive in the evaluation of the truth to move. And then also, understanding the conditions for successful scale up, which is of course contextually bound, but should also be described as this might guide also other scale up initiatives. So this is clearly an area also still in need of methodological development. And I would like again to congratulate you for having brought to the population that can benefit intervention that is, we know, the golden pill, if you can improve physical activity. So really thank you so much. And I would like to just now briefly go to our impact series again. And so as we would like to say, we would like to keep the momentum going, keeping the momentum going with further webinars. The next one is October 20th, which will be Francesca Zuniga, a colleague of University of Basel, who will present the results of the Intercare. Intercare is a nurse-led model of care in Swiss nursing homes to reduce avoidable hospitalizations. And this is a wonderful project where we have learned a lot, and that also implementation science works wonderfully within Switzerland for also very valuable population. We then move more to a policy level in December with Annette Boas of the London School of Hygiene and Tropical Medicine, who will talk about how to strengthen health policy through implementation science methods. And I think the scale up is partially also linked to health policy changes. So the health policy part is something which in the end, I think will in a lot of cases allow us to do certain work, but also might be a limiting factor if it doesn't change, is not part of our radar screen. And then importantly, we have now the formal announcement for our second Impact Conference, which will take place on 2 days, February 10th and February 11th, 2022. The overarching theme is moving towards impact implementation science in Switzerland. The first day, it will be 3 hours from 3 o'clock in the afternoon till 6 o'clock in Central European time, will be a hybrid event. Finally, we will be able to meet in person for those who would like to join us in Basel. And we will have the February 11th, we will have a purely virtual event. Whereas the February 10th will focus on implementation science in action and showcase some of the projects ongoing in Switzerland. February 11th will, on the one hand, give a keynote that shows how implementation science can also be used beyond health sciences and more specifically in environmental health sciences. And at the same time, give an opportunity for the participants to discuss specific methodological aspects of implementation science in workshops. We will have soon more information on our website, and information on impact you will be able to find on our website, by Twitter, or LinkedIn. We also have an email list and also send out email blasts regularly. So it is for us a privilege to be connected with all of you in Switzerland and all over the world. And we really look forward to exchange further. Again, a wholehearted thank you to our two speakers of today from really far away, but so much to be learned and really impressive. Thank you so much. We wish you a wonderful further day in Canada, and to those who are in the European time, I wish you a very, very nice evening and look forward to seeing you again at our next webinar.
Sabina, before we close, can I just say that all of the work that PJ and I have shared with all of you today is really the work of Trojans. We say we do all the talking, but it's our students and our staff that do all the work. So I just want to acknowledge the team over the last 15 years who have contributed to what we shared with you today and to our funding partners as well. So thank you very much.
And we always say implementation science is team sports, and you just kind of showed it again. Thank you so much, Heather, for highlighting this important part of implementation science. You will never be able to do it alone. So many players. And so please congratulate your whole team for the work to be achieved. Bye-bye to everybody, and thank you again.